Sidhu. Sidhu, ready? Go ahead, please.
Ready, sir? Good evening, one and all. Good evening, everyone. Today, on behalf of Endocrine Society of Andhra Pradesh, I extend warm welcome to all the members and guests. This platform serves as a hub for sharing knowledge, advancing research, and promoting endocrine health. So let's work together to foster collaboration, drive innovation, and improve the well-being of our community. So today I'll start our meeting by introducing our guest of honor. He's none other than Dr. Shenoy sir from Trivandrum. He works as an assistant professor in College of Trivandrum, and he's also an EC member in both Indian Thyroid Society and ESA of India. He's a man who needs no introduction, and he's a friend to all. So I welcome you, sir. And I also welcome Dr. Suresh sir, who is serving as HOD of AIMS Mangalgiri. He's well known everywhere in Andhra Pradesh and the National Forum, Faculty Forum. So good evening, sir. Thank you for joining us today. And welcome Dr. Ram Mohan, sir, and Dr. Sunanda ma'am. Sunanda ma'am is our HOD at Narayana Medical College, and she has a good experience. And Dr. Ram Mohan, sir, is an EC member of Endocrine Society of India. And today's presenter will be Dr. Fani. He's a postgraduate from Narayana Medical College, studying second year. He's going to present a case of pediatric bone disorder, rickets. So I think you can start your case discussion, Fani, if everybody is fine.
Okay, sir. Sir, can I start sharing, sir?
Hi, you can start. Green button.
Yes.
Green button, Funny. Okay,
sir. Okay. Sir. So, very good evening to respected professors and my dear colleagues. I am Dr. Fanindra, second year resident from Narayana Medical College, Nellore, and I am here to present an interesting case of rickets. So, coming to case presentation. A 16-year-old girl who is studying in intermediate first year, hailing from Nellore with a background of poor socioeconomic status, presented with chief complaints of deformity of right leg since 6 years of age and poor height and weight gain since 6 to 7 years of age. So coming to history of present illness, patient initially presented at our institute in 2018 at the age of 8 years 5 months with the history of, she had a history of slip and fall with right femur fracture at the age of 6 years. Following which she later developed bowing of right leg, which was insidious in onset and progressive in nature, and there was no associated difficulty in walking. And again at the age of 7, she fell from stairs and had injury over the same right knee, resulting in more deformity. Following which, at the age of 8, she again fell while walking and had an injury over the same right knee. And both times at ages 7 and 8 years, she was attended by a local doctor and was told that there was no fracture, and she was treated with plaster of Paris. And parents also noticed some chest deformity and widened wrist and elbow joints at the age of 8 years. And there was no history while there was a history of climbing upstairs along with bony pains, and there was a history of excessive thirst and nocturia. So
I think you can pause here.
Yes,
Suresh sir is here.
Yes.
Okay. So one thing is, was there a fracture initially? There was a fracture in the
femur, sir. Shaft of femur in the at 6 years, sir. Following, she developed deformity, sir.
Okay. And so it's a young age with a fracture. Was the kind of trauma adequate for producing the fracture, or was it just mild trauma?
Sir, she was saying just there was slip and fall, sir, from standing height. So there was mild trauma only.
And so there was also not only fracture, there's also deformity.
Deformity, sir.
So if a 6-year-old child has developed fracture and deformity, and the fracture is due to minimal trauma, then what are the possibilities?
Sir, it could be due to bone disorder like osteogenesis imperfecta, sir. Or it could be like metaphyseal dysplasias, any skeletal dysplasias, or it could be due to rickets, very weak bones, soft bones associated rickets.
So do the soft bones associated rickets fracture?
No, sir, no, they don't usually fracture, sir. We don't usually see fractures in soft bones, sir.
So if fracture is more common in what about deformity? Do bones deform in rickets?
Sir, mostly long bones, sir. Rapidly growing bones and long bones are most commonly affected in rickets, sir. Rapidly growing bones and long bones are affected.
And what happens in osteomalacia then?
Sir, osteomalacia is disease of adult, sir. It is poor mineralization in adult bones, sir. After bones are fused.
Any fractures happen in osteomalacia?
Sir, pseudofractures can be there in osteomalacia, sir. That is looser zones or pseudofractures can be there in osteomalacia.
Is the incidence of true fractures increased?
Yes, sir.
Where?
I think at the femur and hip they can be, and also vertebra it can be increased.
No, not vertebra.
Um,
It is mentioned as subtrochanteric fracture, transmetatarsal fracture,
Okay.
strange, and rib fracture.
Okay, sir.
Okay, so okay, fine. Go ahead.
So she was also they were also complaining of poor height and weight gain since 6 to 7 years of age, and parents observed poor height gain compared to children of similar age in family or peers. And there was no history of seizures or recurrent chest infections. There was no history of carpopedal spasms or perioral tingling or numbness. And there was no history of delayed teeth eruption or dental abscess or dental caries, sir.
Okay.
So, and there was also no history of abdominal pain, loose stool, steatorrhea, and there was no history of intake of anticonvulsants, ATT, or steroids. And there was no history of jaundice, pedal edema, anemia, or difficulty in hearing or vision. And there was no history suggestive of other chronic systemic illnesses, sir.
So now we have short stature also. Short stature, deformity, and fractures. So does that fit again with these two diagnoses? Osteogenesis imperfecta and
Osteogenesis imperfecta.
Yes.
Does
Does osteogenesis imperfecta have deformities?
No, sir. They usually present with fractures, sir. And deformities can be present, sir. Osteogenesis.
Yeah.
Mostly they present fractures.
All three can be present: deformity, fracture, and
Yes, sir.
okay.
So, at the history of present illness at the current day, she complains of difficulty in climbing stairs, and there was history of nocturia, and also complaining of poor height and weight gain, but there was no history of bony pains. To, present day complaints, sir. This is history of present illness at current day. So coming to
Yeah,
past,
I just like to ask you about nocturia. First of all, let me thank the ESAP team for involving me. So it's a great honor to be with you again. I came to Rajmundri last month. So it's a great honor for me to be with Ramohan Bhai and all of my seniors. So this is an important complaint, nocturia. So can you elaborate why it is important at this age group? What is the relevance? Is there any, you are adding any clue about renal involvement?
yes, sir. Sir, there is deformity, sir, which was involving predominantly lower limbs. There was also associated chest and upper limb deformity associated with nocturia or polyuria with polydipsia. We can think of renal tubular restenosis.
Have you quantified the nocturia into polyuria? That's what next question comes.
Sir,
Did
no,
you
sir.
quantify that? Because this age, the child will not be able to give you the exact volume. So nocturia means nocturnal enuresis can also be one DD. Okay,
Yes.
pediatric age group. Is there any previous history of bladder issues with that child?
No, sir. There was no previous issue of bladder.
You can maybe mention that the child was having bladder control, and now the issue is nocturia. And a school-going child also, first standard is a first standard child.
Sir, now she was inter first year, sir. 16 years old, inter first year.
Now into 60. Okay, this is the age now.
The age of presentation was 8 years, sir, in 2018.
Okay. Now you can carry on. Very clear. Yeah.
Okay, sir.
And this you are talking of nocturia, but what are the causes of nocturia in renal disease of which causing rickets? Which is causing rickets? Which renal disease?
Sir, renal tubular restenosis, sir, and it can also be present in hereditary hypophosphatemia rickets with hypercalciuria, and it can also present in hypophosphatasia, sir. In renal.
So what is the cause for the polyuria?
Sir, in renal tubular acidosis, it is due to hypokalemia, sir. Hypokalemia causes nephrogenic DA, so the polyuria or nocturia is present, sir.
Okay, so one is hypokalemia. Second,
Hypercalcemia, hypercalciuria, sir.
hypercalciuria, how it will cause polyuria?
Hypercalcemia also causes nephrogenic DA, sir.
Yeah, okay. And finally, you can have nephrocalcinosis also.
Sir. Nephrocalcinosis induced tubular damage, sir. Yes, sir. Nephrocalcinosis.
Okay.
So for a starting person, you can mention it's a metabolic bone disease. Okay. Because the first question which the sir asked, no, if you are intelligent, you can just say, sir, it's a metabolic bone disease. It's most likely to be a what you call the nocturia is the catching point here.
Sir.
You can say there is a renal involvement. Yeah. It looks like recurrent fractures may be unlikely to be rickets, but with the clinical history and all these factors put together, it can high possibility of having a renal rickets or those things.
Okay, sir.
Yeah, metabolic bone disease is the exact word you should tell when your examiner points to the first question. Okay.
Okay, sir. Sir, can I move forward?
Yes, yes.
Sir, coming to the past history, she started visiting hospital for above complaints from 6 years onwards, and she was advised vitamin D and calcium syrups that she takes irregularly. And in 2018, before coming to us, patient was diagnosed as having bilateral renal calculi, and some tablets and syrup other than calcium and vitamin D supplements were added. And as per old records, there were deformities in the form of widened wrist joint and chest deformity and board legs are also present before presented to us in 2018. So this is the past history.
So what does this renal calculi show? What does it suggest? Bilateral renal calculi.
Sir, bilateral renal calculi suggest along with nocturia, it most point towards distal RTA, sir.
What is the cause for the hypercalciuria and distal RTA?
Sir, metabolic acidosis, sir. There will be more resorption of bone due to under chronic metabolic acidosis environment. So there will be hypercalciuria, sir.
But then there is metabolic acidosis in proximal RTA also, but we don't get that.
Sir, in proximal also hypercalciuria will be present, sir, but there will be no hypocitraturia. Hypocitraturia is the defect, sir.
No, but then there is still some difference here. No, what is the difference? It is acidosis is there in both. We have acidosis in type 4 RTA. That's stones.
Sir, in proximal RTA, in distal RTA, there will be no hypocitraturia, sir. In proximal RTA, there will be also hypocitraturia. Sir, they are more prone to formation of stones in distal RTA, sir.
But then if proximal RTA is going hypocitraturia, then that should be more prone for stones, no? But here you are saying distal RTA is more prone for stones. And distal RTA is also causing resorption of bone.
Sir, in distal RTA, the proximal tubule is working. There will be increased reabsorption of citrate in the proximal tubule, sir. So there won't be hypocitraturia, sir. Sorry, I got confused, sir. Sir, there won't be hypocitraturia. If there is citrate in the urine, calcium.
No. This is not the reason. The reason is because distal RTA is a failure to excrete acid load. There is a metabolic acid load after digesting your food, after eating your food. Whatever your food and metabolism produces acid, that has to be buffered. So because it cannot be excreted, the H plus cannot be excreted. Ammonia cannot be formed. So who buffers it? Bone will buffer it.
Okay, sir.
So there is no such problem in proximal RTA. In proximal RTA, there is acidosis, but no failure to excrete an acid load. That means if you increase the, suppose I give a acid load in the form of ammonium chloride, what happens? It gets excreted. That's why the urine becomes acidic. So there is no need for buffering the acid. So the reason why the bone is resorbed is the need to buffer the acid. So if the bone is resorbed, you will get calciuria and nephrocalcinosis and calcium stones.
Okay, sir.
That's the basic difference. The need for the skeleton to buffer an acid load. Okay.
So
go ahead.
Sir?
Yeah, go ahead.
Birth history, she was born out of third degree consanguinity and third in order, and there was no significant antenatal history. And she was born at hospital at town in normal vaginal delivery with a birth weight of 3 kg, and she cried immediately after birth, and the natal and postnatal period were uneventful. And there was no apparent deformity noted at birth. So coming to developmental history, gross motor, fine motor, social and visual milestones were attained at an appropriate age, and there was no history of delayed dentition. And she was immunized as per IAP schedule. So coming to personal history, she started going to school at the age of 5 years, and her scholastic performance was good. And telarchy was noted 1 year back at the age of 15 years, and she did not attain menarche. And her appetite was normal, and physical activity has no limitations, and she does her daily activities. Ball had
So there is a delayed puberty, yeah?
delayed puberty, sir.
What is, I think, with all this very simple chronic systemic disease, huh?
This causes increase in pro-inflammatory cytokines, sir. So it causes suppression of Kis15 or hypothalamic.
The suspecting hypothalamic cause for the delayed puberty.
Yes, sir. And sun exposure was
Sunanda madam, anything to add from your side, ma'am? Sunanda madam? Okay, carry on, yeah.
Okay. So coming to nutritional history, she was exclusively breastfed since 6 months of age, and her daily calcium intake was 400 mg per day with a daily total calorie intake per day of 1300 kilocalories per day, and she was on and off calcium and vitamin D supplements. Coming to family history,
you should add more in nutritional history. Okay, nutritional history looks very less. Okay, because the calcium intake also, I think whatever you're eating correctly, because this history is very long term. So medicines also, whether she has taken correctly, we are not sure.
Sir, she was on and off calcium and vitamin D supplements, sir. She was taking irregularly.
Because nutritional things can complicate all these metabolic bone diseases. That is the one thing. Okay, because fluorosis and all, I think your area there is other conditions also. So Golconda and all those experiments. I think, yeah. So that examiner who knows about this, he may ask you nutritional conditions which may have relations, scurvy, fluorosis, all those things can come. How can you roll out all these things? Whether it is adequately met. Okay, some person is very good in this nutrition, they can just catch you somewhere. So maybe you can just, when you are in exam, you can add more in this. Okay. Continue.
So coming to family history, she was born out of 3rd-degree consanguinity and 3rd in order of birth. And the first baby was male and born stillbirth at home at 8 months of gestational age, and there was no apparent physical anomaly noted by mother. And coming to elder sibling, 2nd in order, born in 2007, and she also has history of bowing of both limbs since 3 years of age, associated with chest deformity with widened wrist and elbow joints. This is the history of elder siblings, elder sister. And she also has history of polyuria, polydipsia, and she was similarly diagnosed with renal calculi in 2018.
Oh, that is a big catch. Okay.
And her elder sister birth history includes with the birth weight of 2.5 kg, born at hospital and vaginal delivery. And there was no history of delayed developmental milestones or hearing loss or poor vision or delayed dentition. And patient was evaluated and started on appropriate management, and there was no active present complaints in the elder sister, sir. And she attained menarche in May 2024 at the age of 17 years.
She also had a late. So genetic causes all those things.
So with this history, to summarize, a 16-year-old girl with progressive deformity of right leg from 6 years of age, with deformity of chest, widened wrist joints with polyuria, with history of query bilateral renal calculi on irregular vitamin D and calcium intake, so with similar complaints in the elder sister. So this could be a case of refractory rickets, sir. So my first differential diagnosis, because there is predominant lower limb involvement with nocturia and bilateral renal calculi, my first DD will be renal tubular stenosis, sir. Following the second DD will be hypophosphatemic rickets, sir. And the third
hypophosphatemic rickets will cause which will cause these stones.
Sir,
which form of hypophosphatemic rickets will cause stones?
The hereditary hyperphosphatemic rickets with hypercalciuria, sir. Or X-linked recessive densities is also there can be stones, sir.
Why do those conditions have stones, whereas your garden variety of X-linked hyperphosphatemic rickets doesn't have stones?
They have hypercalciuria, sir. They have hypercalciuria, but there won't be hypercalciuria in X-linked or
why? But why? Suppose if a normal person has low phosphorus, what will happen to the calcium excretion?
Sir, if vitamin D will be increased with normal phosphorus.
Yes.
Yes, sir.
Vitamin D will be increased. Which vitamin D?
Sir, 125 hydroxy vitamin D will increase.
Yeah. because of increased 1-alpha hydroxylase.
1-alpha hydroxylase, sir. Yes, sir.
That leads to alimentary hypercalciuria. That is better absorption of calcium, better excretion of calcium. But that doesn't happen in X-linked hypophosphatemia crickets. Why?
Sir, in there is in X-linked recessive, sir, in dense disease, sir, or
Not in dense disease. The X-linked dominant hypophosphatemia, the classical XLH. Because it is caused by FGF23. FGF23 is a strong inhibitor of
1-alpha hydroxylase, sir.
1-alpha hydroxylase.
So in all diseases caused by FGF23, you won't get hypercalciuria. But in all directly the phosphate is being wasted. Suppose there's a tubular phosphate leak that is direct, not caused by FGF23. Then definitely your 1-alpha hydroxylase will go up and you will have elementary hypercalciuria. Okay. So why this is you have put two diagnoses, RTA and hypophosphatemia crickets. Why this is not hyperpara?
Sir, hyperpara, sir, they don't usually present with deformities, sir.
You can have.
Very
so many deformities are mentioned in classical hyperpara. Of course, they will have deformities, and especially in soft bones.
Soft bones they can have, sir.
In childhood.
Sir.
With genetic history also.
You can have two types of hyperparas here. One is which is of course. You tell me. What is it might resemble hyperpara, but the PTH is not high.
Sir, hyperphosphatation, PTH is not high. Hyperphosphatation, the PTH can be, but more.
So one condition is when you have calcium sensing receptor mutation, but that will not cause calciuria, so there won't be any stones. And that is all very benign condition, doesn't cause much problem, bones and all that. So that's not likely. But what about PTH receptor activating mutation?
So Janssen's metaphyseal not. Yes, sir.
You can see the photograph in the book.
Predominantly lower limbs are involved, sir. Upper. There no chest deformities will not be there in the predominantly metaphyseal long bones metaphyseal ends are involved in.
But we have not got any history of anything like that. No, we just know that there is a deformity, there are stones, and there is nephrocalcinosis. And there is polyuria. That's all we know.
There is just chest deformity, sir, as told by parents. Okay.
You add hyperpara also whenever possible.
Okay,
all that is mentioned in hyperpara also. All kinds of deformities occur.
Polyuria is also there. Renal involvement is there.
Okay, sir. Okay. Sir, and my third differential diagnosis could be hereditary hypophosphatemic rickets with hypercalciuria, sir. And fourth will be VTTR, which is very rare at this age of presentation.
Third should be second, and second should be third.
Okay, sir.
Because it's clear-cut hypercalciuria in this case.
Okay, sir. And fine, fifth and last diagnosis should be hyperphosphatemia, sir. And it is also it can present at this age group, sir,
But most of the features like this polyuria, hypercalciuria, stones, these are not fitting with hypophosphatemia.
I would like to keep at the last TD, sir.
Okay. Yes, next.
Sir, coming to general examination, sir. Patient conscious, coherent, and cooperative, sir. And she was small built and poorly nourished. Blood pressure was right supine position, right upper limb was 100 by 60 mm of Hg, with a pulse rate of 90 per minute regular, with a respiratory rate of 16 per minute, which is thoracoabdominal, and temperature was febrile. Trocheus and Chostek signs were negative, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema, sir.
Have you done Tanner staging?
Sir, I will. There is there, sir. I will tell you. Sir, and there was no evidence of neurocutaneous markers, sir, and the hair was normal, sir, and there was no evidence of bite out spots or cataract, and oral cavity, tongue moist, and there was no glossitis or cheilitis, sir, and there was no goiter, sir.
Okay.
So coming to anthropometry, sir, we are showing at the initial presentation in 2018 and now, sir, 2025 present. At the initial presentation in 2018, her height was 95 centimeters, sir, which was less than third centile, with a height STS of minus 5.3, with a height age of 3 years, sir. There was very severe short stature, with a weight of 12 kgs, which is less than third centile, with a weight STS of minus 3.25, with a weight age of 2 years 3 months. And her BMI was 13.3 kg per meter square, with an intermalleolar distance of 13 centimeters. Sir, coming to anthropometry in 2005 present day, sir, her height was 128 centimeters, which was less than third centile, with a height STS of minus 5, with corresponding to a height age of 8 years 6 months, with a weight of 27 kgs, which was less than third centile, with a weight STS of minus 2.9, corresponding to weight age of 9 years. And her BMI was 16.4, sir, with an intermalleolar distance of 16 centimeters.
Academically, if you can explain how is this intermalleolar distance important for a growing bone, or how do you interpret that?
Sir, intermalleolar distance of more than 8 to 10 centimeters is significant, sir. Suggestive of genu valgus, sir.
Okay, how is it done? How is it measured?
Sir,
in what age do you measure that? Did you measure it? Because now it's still you are measuring, no?
Yes, sir. In present 2005, it is 16 centimeters, sir. In supine position, measure the distance between the two malleoli, sir.
Lateral malleoli.
Medial malleoli, sir.
Medial malleoli. That's what I should tell. Yeah.
Medial malleoli. Sorry, sir.
Yeah.
Medial.
Yeah. So that's how you do. And yeah, so this is, I think, important, because I think that sitting, when a younger child, sitting length, so many other measurements are there. Okay, so it's important to keep a documentation of. It's a good, I think, departmental case. No, you have a long-term follow-up. That's why, because you were not there in 2018. So 2018, somebody resident has done this medicine records. Okay, so examination you cannot write this, but anyway, good. So, but you can see that what is the importance? The weight has improved, no? For a 18-year-old girl, okay, 18, 17-year-old girl, it is only 16-year-old girl, it's only 27 kg. Okay,
yes, sir.
It's really bad. Okay, but we cannot do anything for that. But you are trying. Okay, it's improving with treatment. You can say like that. But still, a short stature is established. Okay, we cannot do anything with that also. So I think, can it be done? We can. Future we'll discuss public health significance. Can we screen early? That's all important. Okay.
Okay.
Carry on. Yeah.
Okay. Sir, coming to head-to-toe examination at the initial presentation in 2018, sir, these are the findings, sir. Her fontanelles were closed and there was no frontal bossing, sir, and there was no dental abscess or no caries, and there was rachitic rosary with widened wrist joints, and there was kyphoscoliosis with pelvic tilts towards right, and there was a right lower limb genu valgum, sir, and there was no double malleoli, and her SMR showed A minus P1 and B1, sir.
Okay, that means just puberty started, huh?
No, sir.
A minus.
Only, sir. At the
A minus, not progressing.
Sir, this is at the age of 8 years, sir. At the initial
8 years. Okay, 8 years. Okay, that should.
8
Okay.
years, in 2008.
Okay. You will compare that also. Yeah.
Yes, sir. These are all the findings in 2018 at initial presentation, sir.
Okay.
So this is the picture showing right genu valgum, sir, light royer limb with normal dentition, sir. So coming to head-to-toe examination in 2005 and the present time, sir, they are showing the fontanelles were closed and there was no frontal bossing, sir, but the rachitic rosary were absent and widened wrist joint was also absent with presence of kyphoscoliosis, and there was pelvic tilt towards right, sir. And the genu valgum of right lower limb is present, sir, and there was no double malleoli, but the SMR showed A2, P2 and B3, sir.
Good. It's improving.
It's improving, sir. And she also entered into puberty, sir.
That means she's coming regularly for her exams, no?
Sir, no, sir. She was not. She was coming regularly from 2024 ending only, sir. Until then, she was not. She was
not coming follow.
Once or twice per year, sir. That's it.
But I think it's a good thing that treatment has continued, no? From 2018 onwards. Carry on.
Can I move? So coming to systemic examination, CVS, there were S1, S2 were held, and there were no murmurs. And coming to respiratory system, there were bilateral normal vesicular sounds, and there were no added sounds. Coming to para-abdomen, there was no palpable organomegaly. Coming to CNS, the higher mental functions were normal, and cranial nerves examination was also normal, with the motor system showing tone normal in all four limbs with the power of 5/5 in all four limbs. And the sensory system was examination was normal with normal superficial and deep tendon reflexes.
Which cranial nerve you suspect a problem will happen in bone disease? Just some question which cranial nerve palsy or whatever. Hearing loss, which condition having bone disease?
Sir,
I will give you
hearing loss can
directly.
be present in genetic causes of RTA, sir. It can also present genetic cause of distal RTA or proximal RTA, sir. Hearing loss can be present.
Okay.
See, you said
Very
there's a very significant height loss. It is 5 standard deviations below normal,
Yes,
isn't
sir.
it?
Yes, sir.
So, what are the conditions which, suppose after initial evaluation, like growth hormone, you have tested, thyroid, you have tested, then what are the obscure causes of short stature which are monosymptomatic? No other features are there, just short stature is there. Any few conditions are there?
Short stature or familial short stature.
Okay, but not so low.
Okay, sir. They're not so low, sir. Or otherwise, rickets. Okay.
I mean, when nothing is there, then you look for these things. One of them is distal RTA.
Also diseases, sir, like celiac disease.
Yes, celiac disease. Celiac disease is there, is one. Distal RTA is another.
Okay, sir.
And of course, Turner also.
Turner. Sir, okay, sir.
Yes.
Yeah.
Sir, can I move on?
Yes.
Good. Turner syndrome is important for the delayed puberty, but familial, as you were told, no, that is not that very common. Yeah.
So,
Is there any difference in the deformity which you find in hypophosphatemic rickets and all these kinds of renal rickets, the type you're talking about right now? So, like this patient has got genu valgum.
sir,
Do you comment genu valgum in hypophosphatemic rickets? Typically in hypophosphatic rickets, you see genu varum, that is outward bowing of the legs, outward or forward bowing of the legs, rather than them coming together in the middle. That is typically seen in all these renal rickets like RTA and in pure calcium deficiency rickets. These are the ones which are having genu valgum. You often find, most of the time if you see any hypophosphatic rickets, you'll find outward bowing and forward bowing of the femur, because the defect is already there in the long bones itself. The shape of the long bones bends. Okay.
Sir, with this history and examination, a 16-year-old girl with progressive deformity of right leg from 6 years of age, associated with deformity of chest, wide and wrist joints with polyuria, with history of carry bilateral renal calculi on irregular and vitamin D and calcium supplements, with similar complaints in elder sister. And on examination, there was severe short stature with the widened elbow joints with genu valgum and kyphoscoliosis. So this points out to a case of refractory rickets. And my first DD can be renal tubular stenosis. Following which hereditary hypophosphatemic rickets with hypercalciuria, following which hypophosphatemic rickets, sir.
Again, which renal loss tubular stenosis are you thinking about?
Probably because of there was history of bilateral renal calculi, so it could be distal RTA, sir.
What about proximal RTA? Does it cause rickets? Pure proximal RTA.
Yes, sir. It can cause ricket.
Have you read it anywhere?
Sir, associated with Fanconi syndrome, it can cause.
Yeah, it is associated with Fanconi syndrome. It is phosphaturia.
Sir, associated with Fanconi syndrome, it will cause rickets, sir.
That's because of phosphaturia. That is hypophosphatemic rickets. That's what I said. It is the inability to excrete an acid load which causes buffering from the bone, which leads to your rickets. Proximal RTA, there is no problem in buffering. The whatever acid load you're taking is getting excreted in the urine is getting acidified. So usually proximal RTA won't cause anything except when there is associated phosphaturia. So it is a form of hypophosphatemic rickets in a way. Okay. So there are some pointers here like nephrocalcinosis, polyuria, stones, and knock knees, which point towards distal RTA. Whereas the more commonly hypophosphatemic type will cause outward bowing of the legs, not really knock knee. And what are other typical features of hypophosphatemic rickets? That's the second diagnosis. Typical features which distinguish hypophosphatemic rickets, especially some of the common varieties from the other types.
Sir, the hypophosphatemia is predominantly present when the child starts walking, sir, at 2 to 3 years of age. and there may be dental abscess, sir. Dental abscess is more common in hypophosphatemia.
Dental abscess. Second?
Predominantly lower limb involvement will be there, sir.
Okay. Third?
Because of the PTH is not raised, there will be no secondary hyperparathyroidism in hypophosphatemic cricket.
Is there secondary hyperparathyroidism in distal RTA?
Sir, it can be there in distal RTA.
Okay. But it's not that severe as it is in vitamin D deficiency because the calcium is normal.
Yes, sir.
Serum calcium. Okay, but the thing is, there are some other differences also. Enthesopathy.
Enthesopathy.
Anything else? What about, you said the patient has no bone pains?
Sir, at the present time, now she is not complaining of bone pains, sir. Initially, there were bone pains, sir.
Okay, so what are bone pains? Bone pains are more common or less common in hypophosphatemic rickets?
Sir, they are more common in hypocalcemic rickets, sir, than phosphopenic rickets.
Yeah. So what is more common in phosphopenic rickets? That also you said it's not there in this patient.
Yes, sir.
What is it?
Predominant involvement of lower limb.
Proximal muscle weakness. You said it's not there, na?
Yes, sir.
But at the same time, you said she could not climb stairs. So I don't know what it means.
Initially, it was present, sir, in 2018. Now also it was. She complains of difficulty in climbing stairs, sir.
But is that difficulty because of some deformity or is it because of muscle weakness? We cannot say very clearly.
We cannot.
So muscle weakness is more common in hypophosphatemic rickets. Bone pain is more common in vitamin D deficiency.
Vitamin deficiency, yes, sir.
Yeah. And what about the bone? Suppose I do the bone mineral density in this patient. What will be the bone mineral density?
So there will be osteopenia, sir. Osteopenia.
Yeah. And what about hypophosphatemic rickets?
Hyperphosphatemic rickets. Hypophosphatemic rickets. There will be osteopenia, sir, because
no, not in X-linked hypophosphatemic rickets. They not only have enthesopathy, they have increased BMD and thickening of the bone.
Okay.
What about the spine in distal RTA? What pattern can appear? Normally, what pattern appears in the spine in rickets?
In rickets, biconcave or codfish vertebra will be there in.
Yeah. And what about the intervertebral space? What is that? What do they say for that?
Intervertebral space will be increased because.
Yeah, but they use a word for that. That is fish mouth.
Fish mouth.
So intervertebral space is fish mouth and the vertebra cord. But what happens in renal kind of pathology when you look at the spine, which sometimes happens in distal RTA also? Rugged jersey. Alternative days, places of like the ends of the vertebra will be osteosclerotic and the center will be will be kind of translucent. So you can have rugged jersey spine in distal RTA also, though more common in CKD. Okay. Then you said VDDR, vitamin D dependent rickets. Why you thought of that possibility here?
No, sir, it is very rare, so I kept it down, sir, because they usually present before 2 years of age. Vitamin D dependent rickets.
This patient presented was 6 years, no?
Yes, sir. So very rare, less probability of VDDR, sir.
But you didn't put nutritional rickets anywhere before VDDR?
Because she was on vitamin D and calcium supplementations previously, sir.
So no therapeutic response?
No therapeutic response. There was progression of deformity, sir, even with vitamin D and calcium supplementation. Okay,
so any investigations are there?
Yes, sir. So coming to investigations which are done in initial investigations, and in 2018 there was showing low phosphorus value of 3.13 mg per deciliter with a low normal potassium of 3.8 milliequivalents per liter with a high elevated serum alkaline phosphatase of 2425 international units per liter, which rules out hypophosphatemia, sir. And there was increase in PTH value of 263 picogram per ml. It rules out hypophosphatemic rickets, sir. And the 25 hydroxy vitamin D level was increased, sir, which was 169.9 nanogram per ml. And there was
that is a toxic level?
Yes, a toxic level, sir.
Very high.
So what happens when the vitamin D goes into toxicity levels?
uh,
The alkaline phosphatase and on and turnover markers.
Alkaline phosphatase and turnover markers will decrease, sir. A bone turnover increase.
What happens when vitamin D is high? Suppose a patient comes with hypercalcemia due to vitamin D toxicity. Can we treat that? Can we treat that with one is you treat with hydrocortisone or any steroid to reduce absorption, but can you treat it with a bone anti-resorptive agent?
Yes, sir.
Yes.
Sir.
Vitamin D is a resorptive principle, not we all think about it as a mineralizing agent, but it just provides enough calcium and phosphorus to mineralize. It doesn't actually do anything on the bone. On the bone, its only action is resorptive. So it can cause resorption, bone resorption. So resorption markers will increase when vitamin D is high. Okay.
Sir, coming to urine examination, her spot urine calcium creatinine ratio was 1.2, sir, which was elevated, signifying hypercalciuria, sir. And there was also spot urine protein creatinine ratio was elevated, which was 0.48, signifying proteinuria, sir. And her TMP GFR was 2.55, sir, which was low for that particular age group. And her BBC revealed pH of 7.2, suggesting acidosis with a bicarb of 15, sir. And there was urine pH was 7, which was alkaline in nature. And there was no albumin or nil albumin and glucose, sir.
So what does it show? This systemic pH is 7.2 and urine pH is 7.
Urine pH is inappropriately alkaline for acidosis, sir. It is showing.
So is there any other condition in which the systemic acidosis and alkaline urine, apart from distal RTA? Type 4 RTA, that is hypoaldosteronism, that also has the same picture. Systemic acidosis and alkaline urine, because there also potassium cannot be excreted. Because one sodium is absorbed and one potassium or one H plus is excreted in reverse direction. So in the absence of aldosterone, there is acidosis because H plus cannot be excreted. So you have a alkaline urine, relatively alkaline urine. But what is the difference between type 4 and type 1?
So there is hyperkalemia in type 4, sir. There is hyperkalemia.
Yeah. Correct. So what is the diagnostic test for distal RTA? This is the only diagnostic test or anything else?
There is, we can do to confirm distal RTA, we can do ammonium chloride loading test, sir. The latest one is furosemide fluoride.
Ammonium chloride loading test. The patient is already acidotic.
Yes.
Bicarbonate is 15, pH is 7.2. That's acidosis. What is the need to do ammonium chloride loading here? So what is the gold standard test for distal RTA?
Fractional excretion.
That may be more of a test for proximal RTA. So what's the test for distal RTA?
We can do
hypocitaturia.
Urinary anion gap. Isn't it? Sodium plus potassium minus chloride minus bicarbonate. What is this anion gap due to? It is due to ammonia.
Ammonia, sir. So
there is actually sodium plus potassium plus ammonia is equal to chloride plus bicarbonate. Here, there is no ammonia production. So sodium plus potassium is equal to chloride plus bicarbonate, or sometimes sodium plus potassium could be more also. Because there are other unmeasured cations like phosphate and all that. So you get a positive anion gap because of lack of ammonia. So that is the gold standard. What about anion gap in distal RTA, in type 4 RTA then?
So in type 4 RTA, in type 4 also
same thing.
Same, sir. Same thing.
Anion gap will be 0 or positive in the presence of acidosis.
Okay, sir. Not as much as high as the distal RTA, sir. It can be.
It is very, very mild. Type 4 RTS, very, very mild. It doesn't cause any bone resorption or anything like that. So mostly it is hyperkalemia that is the problem, not the acidosis. Then what about Okay, what's the gold standard for proximal RTA?
Sir, it is fractional excretion of bicarbonate, sir, after sodium bicarbonate loading test.
Okay.
Okay. More than 15%.
Then any further investigation has been done?
Yes, sir. Sir, she was on a follow-up since then from 2018, sir. She used to come to our institute once or twice per year, sir. And
PTH is also high, no? PTH is also high, no?
PTH is high, sir, 263, sir.
Is there any renal hyper, what do you call that? Hyperpara or something? Do you suspect that also?
We suspect
Why is it part of the disease?
Yes, sir. We suspect secondary hyperpara, sir.
Okay.
So she was coming to our institute once or twice per year, sir. Every time she presented with low normal potassium values along with intermittent hypophosphatemia, sir. And there was also proteinuria, sir. And in August 2025, sir, she presented with severe muscle weakness. And upon investigation, there was severe hypokalemia with 2.4, and there was severe acidosis with a pH of 7.1 with a bicarb of 12, sir. And there was also severe
hypokalemia occur in distal RTA?
Sir?
How does hypokalemia occur in distal RTA?
Hypokalemia, distal RTA. It is the failure of secretion of H plus, sir. So there will be more secretion of potassium, sir. There will be secondary hyperaldosteronism stimulating more potassium.
In distal tubule, there is exchange of one sodium versus either one potassium or one H plus. If H plus cannot be excreted, then potassium has to be excreted. But in type 4 RTA, there is no absorption of sodium, and so forth. There is no loss of either potassium or H plus. So both of them are high in type 4. Whereas in type 1, H plus is not available for exchange. So the body will use K for exchanging against sodium. Okay.
And her urine examination revealed a pH of 6.5 with nil albumin and glucose. And she was put on treatment, and on follow-up after 3 days, the potassium improved to 4.1. There was significant improvement of potassium with 4.1, and with improvement, there was improvement in pH with to 7.32 and bicarb of 18, and there was also improvement in serum phosphate with 2.4, sir. She was put on only syrup, tartrate, soda mint, and CTD, sir. The phosphorus supplementation was not given. And on further follow-up, recent investigations on September 2025, there was potassium was normal with a 4.9 milliequivalents per liter with a normal phosphate of 3.81 with a normal ALP of 233, and VBG showing a normal pH of 7.35 with a bicarb of 20. And on further urine examination, her spot urine calcium creatinine ratio was 0.3, which was mildly elevated, along with spot urine protein creatinine ratio of 0.5, which also mildly elevated, suggesting proteinuria, sir. These are all the recent investigations, sir.
How much is the protein excretion?
Sir, we didn't quantify, sir. 25. We don't do 24-hour urinary protein, sir.
Spot.
No, but when this is a girl now. Now she's 16 years old. So how much grams of creatinine she excretes in a day?
Albuminuria is less than 0.3, sir. Proteinuria is less than 0.2 mg per gram for creatinine, sir.
Okay.
Normal.
Now, so how much alkali do we need to correct proximal RTA versus distal RTA?
Sir, in proximal RTA, alkali we require 10 to milliequivalents per kg body weight, sir. In distal RTA, we require 1 to 2, sir, milliequivalents per kg body weight, but it may increase up to 4 to 6 milli.
But why?
Sir, distal RTA, proximal RTA, the predominant mechanism involved is reabsorption of bicarbs, sir. The defect is reabsorption of bicarbs, sir. So it requires more alkali, sir.
Yeah, in distal RTA, you're only buffering the acid. Daily acid load, you're buffering. So that the bone doesn't buffer it.
Yes, sir.
Okay. Anything else?
These are the reasons.
Yeah, what all conditions do you suspect in a chronic this thing because it's a metabolic bone disease? So do you I think she comes with a frequent muscle weakness, no?
Yes, sir.
So what all channelopathies do you suspect as a leading this?
Hypokalemic periodic paralysis or thyrotoxic periodic paralysis in suspect, sir. If she is coming with recurrent muscle weakness or muscle weakness after excessive carbohydrate intake, we will suspect.
Potassium you have to always check, no? This is actually normal every time.
Yes, sir. Upon correction treatment, she was it was normalized, sir, 4.9.
But this phosphorus is always low, no?
Phosphorus is always low, sir. Whenever she was on intermittent checkups, it was low, sir. And when she was taking treatment regularly, the phosphate was corrected, sir. But she used to take the treatment irregularly, sir. So when she was coming intermittently, there was intermittent phosphate, low phosphate, and normal phosphate, sir.
So you have to give phosphorus also along with this, or you are
not give phosphorus, sir.
But there is no primary defect in phosphorus
yes,
because phosphorus is handled in the proximal tubule. It's not handled in the distal tubule. It is the acidosis which causes the phosphaturia. So correction of acidosis will correct the phosphate.
That's what I wanted to know. Yeah. Sir is a very good teacher. I understood because sir is only giving the explanation to all these. What we really good, sir. I enjoyed it.
So what are the hormones which control phosphate? Which are the ones which promote retention? Which are the ones which promote excretion?
Sir, vitamin D is the one which promotes absorption of phosphate, sir. And
no, renal excretion.
Renal excretion is PTH and FGF23, sir. FGF23 is the predominant one.
And which hormone retains it?
Active form of vitamin D.
No, it doesn't retain it.
The absorption.
Only one hormone retains it. Growth hormone.
Growth hormone, sir. Phosphorus.
That's why in children the phosphorus is a little bit higher than in adults. And what are the influences on FGF? Because that question was there, why some of the FGF hypophosphatemic rickets are not causing hypercalciuria and some of them are causing hypercalciuria. So what are the influences on 1-alpha hydroxylase enzyme? What factors influence 1-alpha hydroxylase?
Sir, PTH promotes 1-alpha hydroxylase, sir. FGF23 inhibits 1-alpha hydroxylase, sir. And
Any others? Any others?
Hypocalcemia also, the 125 hydroxy vitamin D levels increase, sir.
Which one?
And hypocalcemia or hypophosphatemia.
Hypophosphatemia. Correct. Hypophosphatemia, it should go up, but not if the hypophosphatemia is caused by FGF23.
FGF23, sir.
But there are other hormones also which affect it. They are all important from various points of view. For example, growth hormone. What is the effect of growth hormone on 1-alpha hydroxylase?
Stimulates, sir, 1-alpha hydroxylase.
Yeah. Because you require calcium for skeletal growth. What does prolactin do?
Inhibits, sir. Prolactin.
No, why should it inhibit? It also wants calcium to be excreted in the milk, lactation. It is pro-lactation. So it also increases 1-alpha hydroxylase. What about estrogen?
Estrogen also stimulates 1-alpha hydroxylase, sir.
Yes, so estrogen, prolactin, growth hormone stimulate, FGF23 inhibits, PTH stimulates.
Yes, sir.
But probably PTH doesn't directly stimulate, it is through hypophosphatemia.
Yes, sir.
And yeah, so those are the things. What else? What about steroids? What do steroids do to 1-alpha hydroxylase?
Inhibit 1-alpha hydroxylase.
Which 1-alpha hydroxylase?
renal.
Sir, renal 1-alpha hydroxylase they inhibit.
No, it inhibits inflammatory 1-alpha hydroxylase. That means macrophage 1-alpha hydroxylase. Where do we use steroids? We use steroids in sarcoidosis.
Yes, sir.
Yes, steroids do inhibit the absorption of calcium, but that is at the gut level, not at the 1-alpha, not at the renal 1-alpha hydroxylase. Okay, anything else? Next page. Finished, huh?
Yes,
So the other sibling is silent, not much of a problem.
Sir, other sibling was also having the same problem, sir. She was but on regular treatment, and there was no hypokalemia or hypophosphatemia in the other segment, sir. There was deformity, sir, but
she finally attained a good height.
No, sir. She was also very low height, sir. With the STF -3, sir. STS of -3.
Tragedy.
So why do you think the height is affected in rickets?
Sir, it is there is bone resorption, no, sir, and end plates are affected in rickets, no, sir.
Yes.
The growth plates are affected, sir.
It is the growth is not directed vertically but transversely. That's why you have got widened wrist, widened and all that. So it is. So what is the reason why the columns in the metaphysis flare out?
Sir, because there is no apoptosis of hypertrophic chondrocytes, sir. They
So
accumulate.
what causes apoptosis? Phosphate.
Because of phosphate.
So most of the, if you take any rickets except for the distal RTA, all the rickets are hypophosphatemic, including vitamin D deficiency. Vitamin D deficiency rickets are also hypophosphatic rickets, but the only difference is the hypophosphatemia is caused by elevated PTH. So you should consider all rickets to be hypophosphatemic except the distal RTA. That is not hypophosphatemic, but in your case, that is also hypophosphatemic. But that is a minor defect. During the acidosis, there is phosphaturia is also there. So what is the cause for the elevated PTH and the elevated alkaline phosphatase? In this case, when the calcium is normal, the vitamin D is normal, everything is normal, why is the PTH going up?
Sir, initially the PTH was high, sir, and at the initial presentation. There was hypercalciuria, sir. Initially, when she presented at that time PTH.
Hypercalciuria is due to resorption, not due to. So when the bone gets resorbed on its own, then it should suppress the PTH, no?
Sir, and there is also hypophosphatemia. The hypophosphatemia mildly stimulates PTH elevation.
Okay, so you think that. Well, the actual answer is nobody knows. So you are saying that it is hypophosphatemia. So does the phosphate have a stimulatory influence or inhibitory influence on PTH? Acutely, it doesn't have. Acutely, there are only two things: calcium and vitamin D. But is there any evidence that phosphate also causes PTH, affects the PTH in some way directly?
Hyperphosphatemia stimulates PTH.
Yes, it does. That is why you get 4-gland hyperplasia and CKD. But it is not very clear. It's difficult to tease it out whether it's a direct effect on PTH or by lowering the calcium or by lowering 1-alpha hydroxylase. Phosphate lowers 1-alpha hydroxylase also. So it is not very clear whether it's a direct action or not. So there's no reason for PTH to go up in distal RTA. Calcium is normal, vitamin D is normal, yet it does go up. And again, there's no reason for alkaline phosphatase to go up. Why is there osteoblastic activity going on right now? But it does. Alkaline phosphatase also goes up in distal RTA. Exactly, we cannot say why it happens that way. So anything else in this patient?
Nothing, sir. Sir. So, sir, coming to X-ray, sir, these were old X-rays, sir, before 2018 when she presented before to us. And the X-rays were showing widened growth plates with widened metaphysis, and there was splaying and fraying of the metaphysis, sir. And there was widened growth plate, sir.
So the splaying is the one which is causing the reduced vertical height gain. But it's not that the amount of splaying is equal to the loss of the height. It's not like that, but it's not growing in a proper way, not in a coordinated way. But the other thing is that the height is compromised because of the deformity also. So if you measure along the deformity or if you correct the deformity, you'll get a little bit of height more. So bored legs, genuvalgum, these also will compromise height. Kyphosis, scoliosis, all will compromise height. But there is a genuine compromise in height also because of this, as you said, misdirected or lack of senescence or lack of direction in the growth plates due to lack of phosphorus. Apoptosis, as you said.
Sir,
okay.
These were X-rays in 2018, sir, when she presented to us. And there was mild radiolucency over lateral condyles, sir. But there was partially showing radiological lines of healing, sir. She was in a irregular treatment, so there was some partial radiological signs of healing, sir. And these were the latest X-rays, sir, in 2025. And there were the bones were almost fused, and there was osteopenia with cortical thinning, sir.
So why osteopenia with cortical thinning?
There's due to secondary hyperpara or
secondary hyperpara. Yes.
That's it.
So coming to USG abdomen, this is the latest USG abdomen, and showing kidneys of right kidney of 9.2 centimeters with the left kidney of 9.3 centimeters. They were both normal in size, and now there was not cortical echo texture and thickness, but showing echogenic renal medulla, which was noted in both kidneys, suggestive of bilateral medullary nephrocalcinosis. So
periodically, do you want to do this ultrasound? Because in a asymptomatic patient, do you want to do it? Is there any recommendation?
we should do, sir. In a symptomatic patient also, we should do to rule out nephrocalcinosis, sir.
Okay.
So with this history, examination and investigations, a 16-year-old girl with progressive deformity of right leg from 6 years of age, with deformity of chest, widened wrist joints, with polyuria and with history of bilateral renal calculi, and on irregular vitamin D and calcium intake, with similar complaints in elder sibling. And on examination, there was severe short stature, widened elbow joints with genu valgum and kyphoscoliosis. And investigations revealed normal anionic gap metabolic acidosis, and there was hypokalemia, alkaline urine along with hypercalciuria with intermittent low phosphate with renal phosphate wasting and proteinuria. And radiological findings include rickets with bilateral medullary nephrocalcinosis, sir. So the possible differential diagnosis in the above child from these findings would have been distal RTA, sir, but the points against are hypophosphatemia due to hypophosphatemia and proteinuria. These points are against distal RTA, sir. But it can also be primary distal RTA with acidosis and hypokalemia induced secondary proximal tubular dysfunction, sir.
Exactly. That is what's happening. In fact, distal RTA can have normal or low phosphorus.
No phosphorus. So it can, and the less common, and the other one is proximal RTA, but the urine pH and nephrocalcinosis points against proximal RTA. And the primary hypophosphatemia kids with hypophosphatemia induced secondary distal RTO. But in the primary hypophosphatemic rickets, the PTH will be suppressed, sir. PTH will be normal, sir.
Yeah.
And in hereditary hypophosphatemic rickets with hypercalciuria and with hypophosphatemia induced secondary distal RTA, the PTH will be but in this the PTH will be suppressed, sir. So, sir, can I move forward, sir?
Yes.
So we have sent genetics to the elder sister, but we couldn't send to younger sister, sir, because of financial constraints. And the genetics in elder sister revealed the gene defect in SLC4A1, sir, which is distal renal tubular stenosis with hemolytic anemia, and the inheritance is autosomal recessive. So we made a final diagnosis of primary distal RTA secondary to SLC4A1 mutation, sir. So with this, we have made a provisional diagnosis in the younger child of primary distal renal tubular stenosis with proximal secondary proximal tubular dysfunction, sir, with bilateral medullary nephrocalcinosis.
Very good.
Yeah.
And the department has got a good. So did you made the person pay for this test, or they do it like
Sir, for elder
concessional?
sister, we have done it, sir, but younger sister we didn't send, sir. They couldn't pay, so for elder sister, we have sent it, sir.
Genome, no?
Sir, medicine.
It costs 20,000,
No, sir, it is 8,000 only.
8,000 only. Okay. Specifically, you should mention. Then they will only do
yes, sir.
sequence. Yeah. Very good case. I think we have seen many, but I think we have presented very neatly. Over to sir and madam.
Sir,
I have already said
really great discussion. Okay.
Sir,
so if there are any pediatricians out there, because I think it will be relayed on YouTube also, I believe. So I think this is a good PACE presentation done by Dr. Funny. And the important point is that metabolic bone diseases in children, it's actually a growing age group. And we are to be very cautious about the growth, the metabolism, then the development, and finally the puberty. So because the growth is affected in this child, the puberty is affected in this child, and also the height is also finally not reached. So whatever we say and do, I think public health importance is also there. So I think one of the important take home, before we go to take home itself, I think vitamin D is actually a hormone. So before I think we all understand, vitamin D is a pro-hormone, we can say, and there are so many other hormones involved in the bone metabolism. So we should actually screen whenever possible in a public platform, whenever you get children with bowed legs. When you have a family history like this, very clearly the other sibling should be definitely be told. When you have a public health any school program, you should definitely screen them. And endocrine health is priority, because I think at Nellore, we are soon having a ESI satellite symposium. We'll definitely look forward to suggestions, because we need a lot of impact in public health in pediatric bone diseases. It's a very important entity, because the loss to the community is huge, because it's not only vitamin D deficiency included in the metabolic bone disease. It's a huge variety of growing skeletal issues. As sir has very beautifully elucidated, it can range from a simple variety of nutritional rickets to the very large variety of X-linked rickets. It can be even genetic causes. It can be very rare conditions. But unless you have an endocrine team with you, you should always reach out to endocrinologists, because that is the one barrier which maybe you are lacking in that area. So that's why we need to have discussions. I congratulate the ESAP for this wonderful program, because I think the pediatric population definitely will benefit from this. Carry on.
Sir, can I move forward with discussion, sir?
Yes, please.
Sir, coming to definition and types of renal tubular stenosis, sir. Renal tubular stenosis is a group of disorders where the kidneys cannot properly acidify the urine, leading to normal anemic metabolic stenosis, sir. And there are 4 types of renal tubular stenosis, sir. Type 1 is distal RTA, type 2 is proximal RTA, type 3 is mixed RTA, and type 4 is hyperkalemic RTA, sir. So the primary distal RTA, coming to type 1 distal RTA, distal renal tubular stenosis is the classical form, being the first described, sir. It is characterized by the failure of acid secretion by the alpha intercalated cells of the distal tubule and cortical collecting duct of the distal nephron, sir. So the causes can be divided into genetic and acquired secondary causes, sir. The genetic causes include either mutations affecting H+ secretion or mutations affecting bicarbonate reabsorption, sir. The mutations affecting H+ secretion include ATP6B1B1, which encodes B1 subunit of H+ ATPase, and the inheritance is autosomal recessive. It is associated with early onset sensory neural deafness, sir. And the second one is ATP6V0A4, which encodes A4 subunit of H+ ATPase, and it is also autosomal recessive inheritance, and it can also cause hearing loss, but it is sometimes later in life, sir. And the mutations affecting bicarbonate reabsorption involve SLC4A1, which is anion exchanger or chloride bicarbonate exchanger in distal tubule, sir. And it can be inherited as autosomal dominant or recessive, and can also be associated with spirocytosis or ovelocytosis with hemolytic anemia in some cases, sir. And the other genes which are involved are FOX11 and WDR72. And the involvement of WDR72 can cause amelogenesis imperfecta, sir. These are some of the other rare causes, genetic causes, sir. In coming to secondary causes, and some of the autoimmune disorders, which include hypergammaglobulinemia, Sjogren's, primary biliary cirrhosis, or SLE, can cause associated with drugs like amphotericin B, toluene, and tubulointerstitial diseases like obstructive uropathy and renal transplantation can also cause distal RTA, sir, along with hyperparathyroidism. So coming to the differences between type 1, type 2, and type 4 RTA, the urine pH is mostly greater than 5.5 in distal RTA, but it is usually less than 5.5 in type 2 and type 4 RTA, along with low potassium in type 1 and type 2 with high potassium in type 4 RTA, sir. These are the important differences between these types of RTA. This is the picture showing the defects in each RTA, sir. In the proximal RTA, the chloride bicarbonate exchanger is the defect involved in genetic causes. In the distal RTA, in the alpha intercalating cells, the either H+ ATPase or chloride bicarbonate exchanger on the basolateral numule are involved. In the type 4 RTA, which is due to hypoaldosteronism or aldosterone resistance, sir. So coming to the distal RTA and proximal tubule dysfunction, rickets, other than those associated with advanced CKD or isolated distal renal tubular stenosis or hypophosphatemia, are usually associated with hypophosphatemia, sir, due to abnormal proximal tubular reabsorption of phosphate. However, distal RTA at times can be associated with completely reversible proximal tubular dysfunction. On the other hand, severe hypophosphatemia of different etiologies may also interfere with both distal tubular excretion and proximal tubular function, giving to transient secondary renal tubular stenosis, which may be distal or proximal, sir. So hypophosphatemia and non-anionic metabolic stenosis that pose a diagnostic challenge occasionally. So this is the original article in which there were 16 out of 24 patients of distal RTA presented with proximal tubular dysfunction, and none had glycosuria, but the proximal tubular dysfunction resolved after resolution of acidosis and hypokalemia. This is another article which was from southern part of West Bengal in India. In this, 29 out of 30 patients had reversible proximal tubular dysfunction, which improved with correction of acidosis and hypokalemia, and none had glucosuria. So, how distal RTA causes proximal tubule dysfunction? The mechanisms proposed are metabolic dysfunction leads to lysosomal dysfunction, leading to impaired protein degradation, leading to proximal tubule dysfunction, sir. This is one of the proposed mechanism of proximal tubule dysfunction, and the other is hypokalemia causing multiple structural changes in proximal tubule cells. These are the two mechanisms which are involved in secondary proximal tubular dysfunction in distal RTA. So,
see, if you look at, you said that proximal RTA causes hypokalemia, but how does it cause hypokalemia?
Sir, that is what, sir. The proximal RTA Some more distal sodium delivery is there, sir. So there will.
So in the proximal artery, you should imagine a person taking acetazolamide. If a person takes acetazolamide, he develops proximal RTA, but he will develop hypokalemia. But it is used for the prevention of periodic paralysis. But if a normal person takes, if a person with periodic paralysis takes acetazolamide, he won't develop hypokalemic periodic paralysis. But if a normal person takes acetazolamide, he develops hypokalemia because of what you told. Distal delivery of, it's a diuretic. Acetazolamide is a diuretic. Like Lasix will cause hypokalemia, thiazide will cause hypokalemia, acetazolamide also causes hypokalemia. So that is the mechanism. The other important thing is that this PTH which you get in distal RTA, PTH, that PTH also can cause proximal tubular, two types of proximal tubular dysfunction. One is phosphaturia. PTH causes phosphaturia. And secondly, PTH also causes proximal RTA. PTH also causes bicarbonaturia. This is one of the physiological actions of PTH. Not only it causes phosphaturia, it also causes bicarbonaturia.
Okay, sir.
So all tests for proximal RTA will come high if the PTH is high. Okay, it's a good case.
Yes.
Well discussed. Nice.
Is it over? Next slide.
Thank you, Mohan Chandra, sir.
Okay. I think the audience has asked some question. Can we take it up? One question from Dr. Rajpal.
Yes.
Sir has also
Sorry, sir,
congratulated.
my phone got disconnected. My internet got disconnected. I'm joining via phone, sir. So there are two questions. Like there is only one question over here, sir, from Dr. Raja Paul. Like, good evening to all. Apart from this case, I would like to know whether you have come across any cases of nephrocalcinosis induced by high intake of vitamin C. Can Shania sir or
Vitamin C. Vitamin C.
Vitamin C.
Vitamin C, sir.
Long term, maybe.
Yes,
I have not seen, but maybe it's a. We see some cases of herbal issues. So many people eating other causing so many other. But I think vitamin C is not a usual. Puli and all we have heard causing irimban puli and all we have heard causing so many renal issues. We have not heard about vitamin C particularly.
I think vitamin C is a water soluble vitamin. Water soluble vitamins very rarely cause any toxicity because excess vitamin will be simply excreted in the.
Simply excreted, yeah.
But if the problem is with the fat soluble vitamins, vitamin A can cause again hypercalcemia. Potentially, it can cause nephrocalcinosis. Potentially, vitamin A can cause that. Of course, it can also cause raised intracranial tension and all those kind of things. If you look at vitamin D, that is also fat soluble vitamin. So I think it's the fat soluble vitamins which really cause problem, not the water soluble ones. I'm not aware of any nephrocalcinosis caused by vitamin C.
Maybe rare case report, but I don't think it's very common. Yeah, in our part at least. Thank you, sir. And really, sir has also appreciated Dr. Suresh sir's teaching. I think we are all used to it. He came to Amrita when I was there, so we have heard sir directly. So
anyway,
Praveen sir always tells me about you, sir, because you are both from the same area. He is also my teacher. So thank you, sir. I really enjoyed being with you.
Thanks for the opportunity.
Yes, sir. Same here, sir. Thank you.
Ramkumar, where's Ramkumar?
He's the host. He's somewhere here around. Dr. Sunanda, thank you for being here. Any
Thank
points
you,
to be added?
Dr. Mohan.
Your side,
Special
anything?
thanks to Dr. Suresh, sir.
Thank you.
Sir, very lot. It is useful for us.
Thank you, madam.
Ramon, thank you so much. You given to us this opportunity for a long discussion about rickets.
Your student did very well, madam. Your student is very good. Your teaching also.
Thank you.
So I think the take home from my side is, I think you should see more of pediatric cases in your practice to be an expert like Suresh sir, because I think we are trained in both adult and pediatric endocrinology. There are so many courses which are opening, calling they are the true pediatric endocrine. We should not go into anything like that. Our DM endocrinology curriculum has so much of pediatric also into us. So we should actually start going into pediatric endocrine as a routine practice. We should always encourage them to come to us and always do a pediatric endocrine outreach programs whenever possible, because when they have school, when they have some issues, they may not come to you. So you have to do some outreach like a school camp when possible. We try to do that. Or Saturday, you can do special OPD for a pediatric endocrine cases. but don't restrict yourself to only adult endocrine, because I think pediatric endocrine is one of the major things which we always practice. So I think bone disorders are also very important, because you lose the patients a lot of importance when you don't manage it correctly, or when you are late in managing it. So growth hormone deficiency, obesity, short stature, you have so many other causes like CAH. So adding to this, rickets, rare forms of rickets are also there. So I think we should always appreciate that we are a team. You team up with the pediatrician over there. You ask your hospital to also give you cases of pediatric endocrine, and you also practice in your, you can learn more with your practice. So you should not stop learning after you become an endocrinologist, because I always enjoy being with academic programs. That is why Dr. Ram Mohan actually involved me. Thank you, Ram. Over to you. You can give the, maybe tell how it was. Yeah.
Ram Mohan, sir. Sir, is sir there, sir?
Yes, yes, he's back. He's back. Yeah.
Thank you, Dr. Mohan Shanai, for your wonderful insight. And thank you, Professor Suresh, sir, for your wonderful
Thanks.
and you're always there as a backbone for all the ESAP students, sir. Thank you so much. Thank you, Dr. Sunanda, madam. So we'll try to continue our academic schedule as per every month. Thank you for all the encouragement. So now to Dr. Sidhu.
Yes, sir. Thank you so much, sir. Thank you, Suresh, sir, and Mohan Shenoy, sir, for your valuable insights. We learned a lot from this case when managing this patient, sir. The patient used to tell that she was very compliant all the time, but we really got to know the picture when she got admitted with severe hypokalemia, and then which got resolved, which improved within 2 days. Then when we re-examined her, she said she's non-compliant. That's when her true things came out, and that's when we were able to truly treat her. So I think we learned a lot from this discussion also. It was really helpful for all our young endocrinologists. So I would like to conclude this meeting by telling vote of thanks. So thank you for all your valuable participation today, all the participants. Your insights and collaboration are really appreciated. And let's continue to work together for the betterment of endocrine health. Stay connected and inspired. Thank you so much.
Good night.
Good night. Thank you.
Thank you, sir. Thank you.